Okay, so now we're going to talk about the antiplatelet drugs. And so these drugs have a profound effect on the actual platelet activity. Oh, sorry. This is a nice summary table looking at um, all the different molecules that are produced by endothelial cells that really play a huge role in clot formation. And so this is kind of a nice review of physiology, and just kind of put everything into kind of perspective, especially looking at some of the biochemistry and some of the physiology behind platelet activity. This is a great summary table. Here we're looking at the three main drug classes that have major platelet inhibition activity. Aspirin, of course, which is a COX-1, COX-2 inhibitor, basically prevents platelet adhesion and secretion. If you administer aspirin, there's a dramatic inhibition of COX-1, which basically inhibits thromboxane pathway as well. And this lack of thromboxane really kind of reduces the platelet recruitment and activation steps. Ticlopidine, prasugrel, these are ADP receptor antagonists. And so if ADP doesn't bind to its receptor, you get a dramatic reduction too in terms of platelet recruitment and activation. And so this is actually why we co-administer these drugs. We've probably talked about aspirin and ticlopidine or clopidogrel in the STEMI cases and the myocardial infarct curriculum. And this is, I would say, kind of rare for two such closely kind of related drugs to be co-administered, but they seem to work well together. And so, if you got the post-STEMI patient giving aspirin plus one of these, typically clopidogrel or prasugrel, really is a nice, gentle inhibition of platelet recruitment and activation, and you see these patients not forming clots quite as readily. Of course, there's the drug category we just talked about. Mechanistically, abciximab and tirofiban will inhibit glycoprotein 2B activity, which has another consequence in terms of platelet activation and aggregation. Let's talk about aspirin a little bit. Aspirin, acetylsalicylic acid under the acronym ASA. Great drug used for a long time. Reduces the incidence of myocardial infarct and death in patients with unstable angina. And it seems that the low-dose aspirin appears to be the most therapeutically relevant. And so, you can give aspirin doses. The low-dose aspirin is typically 81 milligrams. The second and third dose include 160 and 325 milligrams. Sometimes you can see physicians, especially patients that are hemodynamically unstable, be put on maybe a higher dose aspirin for 3 to 6 months post-MI, and then moved over to the low-dose aspirin once the physician is convinced that the patient is a little bit more stable. But we do know that if you give aspirin post-MI, that the mortality is going to be severely reduced. And so that's a good thing. We want to maintain these patients on thin blood, and we can accomplish that with aspirin as a monotherapy, but more often in combination with something like clopidogrel. Aspirin has really quick oral absorption and distributes throughout the body. Mechanistically, we call it a direct antagonist of the prostaglandin thromboxane pathway due to irreversible acetylation of the COX enzymes. It is both a COX-1 and COX-2 inhibitor, which is why it's a pain reliever, fever reducer, and non-steroidal anti-inflammatory drug. Okay, and so the therapeutic dose ranges are there. Again, you don't have to memorize them per se, but I think from a clinical standpoint, it's good to know. Low-dose aspirin is typically reserved for, the platelet inhibition effect. You can see high-dose aspirin for antipyretic, so fever inhibiting, and high doses for anti-inflammatory effects. But typically we don't use aspirin as an anti-inflammatory because there's a lot of GI upset that's associated with it, but it can be. One thing I do want you to remember is that aspirin therapy is, when you look at platelet activity, is essentially irreversible for the life of the actual platelet that you're giving it to. And so most platelets last anywhere from what, 7 to 9 days. That dose of aspirin that you give essentially is going to inhibit the COX enzyme in those platelets for 7 to 9 days. Okay. Aspirin as a molecular target, remember back from biochemistry that arachidonic acid feeds into the cyclooxygenase pathway, and then these peroxidases convert some of these prostaglandin precursor molecules into thromboxane, as well as prostacyclin and some of these other prostaglandins listed here. And so, aspirin has, dramatic effects on many of these prostaglandins, as well as thromboxane. The major toxicities, hi Sophie. The major toxicities include bleeding and gastric. So some of the major toxicities include bleeding and gastric upset. A lot of patients that take long-term aspirin therapy start to complain of gastric ulcer or peptic ulcer. And so you can see kind of, chronic long-term use. You can see some upper GI bleeding. There are some renal effects that are associated with aspirin therapy. You can see toxicities occurring during episodes of acute renal failure, as well as some different forms of nephritis. Okay, so I think we'll end there about aspirin, and we will continue with the other drug classes next.